Yeah, Rakibul. My name is Rakibul. So yeah, I'm fine, doctor. Thank you.
Rocky, I'm one of the pediatric doctors here. So today I would like to examine you. Are you okay with this?
Yeah, yeah, please.
Okay. Uh, so is Rocky comfortable?
Yes, he is comfortable.
Okay. Any devices around Rocky?
No, no.
Okay. Uh, okay. I would like to Rocky. I would like to plot his height and weight on a growth chart. To me, it looks well nourished. Although I would like to plot class and on general examination, I would like to start from the hands. So, is there any cyanosis clubbing in the fingers?
No sinuses, no problem.
Okay. Uh, how is any abnormalities in the fingers?
No abnormalities, only a pale.
Okay. Pale.
I mean,
Okay.
pallor is there in the male bed.
Okay. How are the pulses? Is it well volume?
Yeah, that is
Any
also that is
okay. Any
also
radio femoral delay?
your your task is open the abdomen.
Okay.
Okay.
Examine the abdomen.
Mm.
Okay. 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 In the leg, any swelling is there in the feet? Any edema?
No.
Okay. On general examination, on head-to-toe examination, I can find the head looks normal, the eyes looks normal, Mrcpch is depressed, and his cheeks look puffy and bloated. And I would like to examine the mouth and oral cavity for any abnormalities in the palate, in the gums, any ulcers, any pigmentation.
Okay. Some dental malocclusion is there, and rest of the thing there is no such specific finding, but pallor is there.
Okay. In the neck, any palpable nodes, any scar marks.
No.
Okay. On examining his chest, abdomen, any scar marks, any deformities in the chest,
No.
any any scar marks in the abdomen.
No.
Okay. In the legs, anything abnormal on inspection,
No.
any pigmentation, scar marks.
No.
Okay. I would like to examine his back also, any kyphosis, scoliosis, any
No.
deformity.
No.
Okay. I would like to examine the abdomen. So before examine, I would like to ask permission from Rocky. Are you comfortable if I palpate? Do you have any pain in the abdomen?
No pain.
Okay. So on inspection of the abdomen, how is the shape of the abdomen? Is it distended or
Yeah, slight distended, but apart from this, no positive finding.
okay?
Inspection.
Uh, any visible veins, any scar marks,
No.
sinuses?
No.
Okay. Uh, fine. So I would like to palpate the abdomen. So I would like to do superficial palpation for any tenderness in the abdomen,
No tenderness.
any guarding rigidity.
No.
Okay. Uh, I would like to do deep palpation for any organomegaly. So to like to examine the liver and start from the right iliac portion, go upwards. So am I able to palpate the liver?
Yes, 4 centimeter below the costal margin.
Okay. Uh, how is the margin and borders?
Sharp, firm, and smooth.
Okay. Is the left lobe of liver palpable?
And that is also enlarged, but not significantly, just like the right leg.
Okay. And I would like to examine the spleen. I would similarly start from the right iliac portion and go towards the left side, left costal margin. Is the spleen palpable?
6 centimeter below the costal margin.
Okay. Uh, I would like to, at this point, I would like to examine the kidneys also for palatability and if I'm able to palpate it. Are the
Okay.
kidneys palpable?
No, not difficult to palpate.
Okay. Uh, so since the liver is, since the abdomen looks a bit distended, I would like to examine in the midline for any mass.
Sorry?
Uh, any mass in the midline
No,
from
no mass.
uh, okay. I would like to look for fluid chill and shifting dullness. So I would like to examine from the just below the ZP sternum and towards the umbilicus. I would
Negative.
like to pulcus. Okay.
Negative.
And I would like to look for fluid chill. And is it chill present?
Negative.
Okay. So I would like to auscultate for any abdominal bruit.
Nothing is there. Negative.
Okay. I would like to check for any hernial sites for any
Negative.
hernia. Okay. At this point, I would like to also do a Tanner staging and genital examination if I'm allowed.
Okay. Well, your time is up. Present is this.
Okay. So today I examined Rocky Bull. He's 14 years of age. He had pallor, and on general examination, he had a depressed nasal bridge, dental malocclusion, puffy cheeks, and on specific examination, I could find he had a hepatosplenomegaly, and so I would like to do a complete other systems examination for this child and do some specific tests to confirm my finding.
Well, what is your most likely diagnosis?
So my most likely diagnosis at this point, so my first differential would be storage disorder. My provided this hepatosplenomegaly along with puffiness of cheeks and distended abdomen. My second differential, although I didn't check for icterus, so but with the hepatosplenomegaly, I also like to consider chronic hemolytic anemia.
Okay, so yes, continue. Third
differential.
Okay, how will you investigate this child?
So investigations, I would like to check for a full blood count, which includes hemoglobin, and I would like to do peripheral blood smear to look for any abnormal cells, any signs of hemolysis, and I would like to do ultrasound of the abdomen and if I'm
ultrasound for what?
I mean, any abdominal masses apart from this hepatosplenomegaly and any enlargement of kidneys, although I couldn't palpate.
Okay, so
and I would like to check the renal functions, liver functions, the ferritin levels, other iron indices for this child. And specific for storage disorders, I would like to check the urine for glycosaminoglycans and optal examination. Investigation. And maybe involve a geneticist. I'm concerned regarding some.
Well, thank you. Your time is just up. Okay, so Dr. Shandan, are you happy with your performance?
So not entirely happy, but I think management, the investigation part I was asked, should I tell the management also at this time or?
That comes later, but if you are not right track, then everything is wrong. And the thing is, most important thing is they will be, if they are giving a clue, that's fine. They will try to give some hints, and if they are giving some clues or hint, they will deduct the mark. But here I was not giving any clue, but in abdominal station, what you missed initially, that is very, very important, because in my class, again, I said, whenever you are examining a child, there will be two different types of cases. Okay, number one, and that should be demarcated. Just a minute. Sorry. It. Sorry. So the thing is, in abdomen, like suppose you have got the case of abdomen, then please try to remember this one. You need to observe for jaundice. Because there may be varieties of cases, but most commonly they're giving the cases of either hepatomegaly, okay, either hepatomegaly or hepatosplenomegaly. Suppose this is the lipostomia. So these two finding mostly they're giving in our Mrcpch exam case. This is a very common exam case. Okay? So if you are getting hepatomegaly, then you need to think according to that. If you are getting splenomegaly only, then again you need to think about the disease of splenomegaly. And if you are getting both hepatosplenomegaly, then disease will be slightly different. That is a typical thinking in abdominal cases. The most common cases. I'm not going to the varieties of cases. There may be, varieties of cases may be there. Please, guys, mute yourself, please. So varieties of cases may be there, but most importantly, if you are getting any child with hepatosplenomegaly, please try to confirm whether there is jaundice or not, because that will give rise to two different way. Either if jaundice is present, that will direct you towards chronic hemolytic anemia, right? And if you are getting without jaundice in case with hepatosplenomegaly, then this is most likely storage diseases are the very common exam case. But here Dr. Shannon, why you missed these faces? Do you think this is a storage disease faces? What are the features in this face?
This a broad forehead I missed and depressed nasal bridge.
Okay, this one first, depressed nasal bridge, that's also expected. And anything?
This dental malocclusion was also fine.
Okay, that is also fine. Another?
And this jaw looks
this is bit
looks like a typical hemolytic cases actually, but
yeah. So why you have got so confused? So this is maxillary hyperplasia typically. So this will give us, whenever you see this kind of patients, you need to pick up the cases all of a sudden, just like, okay, this is thalassemia, nothing else. Chronic hemolytic anemia, and after that, what will we have? So you will be, having that much of confidence. So this is thalassemia. You go to hepatosplenomegaly quickly and see the, liver, your, kidneys and all the, steps of examination. After that, present your case confidently. So that's why I said in whenever I am discussing with you guys, so please, whenever you are entering the room, try to observe. This is the key basically. Again, I'm repeatedly telling, this is the key. Face. Try to read the face. Try to identify. Few features will be there. Apart from face, what we usually do in our day-to-day practice. When someone enters into our clinics, just we look at the face first, right? So look at a bit more time, try to pick up the clinical finding, and that will give you some ease if you are getting the clues from the first look. Right. And after that, you started with the hand, that's fine. Puberty, you understanding mentioned, but you started with CVS. So maybe that was your opening statement. You have not listened carefully. That's maybe the reason. But in abdominal station, pulse you can examine, definitely that's important. But apart from this, do not waste your time, because simple kind of cases in abdominal station, you should not just waste your time in looking for some unusual feature. This is straightforward case. This is most common exam case, straightforward case, especially in overseas area. So you will definitely get. So I'm not discussing the examination technique. I think everybody knows that. Okay. So what I'll discuss, what are the possibilities? So here you are getting this phase is along with hepatosplenomegaly. This is your chronic hemolytic anemia, and this is very common exam case. That does not mean there will be just only this case. Some cases there may be only hepatomegaly. Okay. Some cases there may be only splenomegaly. So according to that, you need to just think your DDs and they discuss the most likely diagnosis and after that investigation and management. Okay, so let's discuss this one. So as this is a very important and most common exam case. So uh, the exam technique I'm not going into detail because I think you all know now. So you can go to the YouTube to see the steps repeatedly, so that you should not forget. So what you missed, Dr. Shantan, here you missed the percussion that to find out the liver span and spleen measurement. And the measurement is important. So this was the uh, case actually for you. And a few discussion important point they will ask about the thalassemia cases. So after you know present after you when you are presenting your case, then they will ask what are the clinical features maybe you have observed. You will present again if you are missing during your presentation. And after that, pivotal staging is important, you mentioned, but here you need to also include the hepatosplenomegaly cases. You must look for lymphadenopathy. Okay, do not miss. And after that, they will ask few question. Okay, that suppose this is okay. You are presenting as like chronic hemolytic anemia. So what are the conditions? Just like beta thalassemia, sickle cell anemia, GCPD deficiency, and hereditary spherocytosis. So you can mention last, GCPD deficiency, but before that, hereditary spherocytosis. In their country, that is, these are the common cases. But over in India, you can get lots of thalassemia, even without any facial features, typical hemolytic cases, without any. Because if this is well treated, or the hematologist managing this child, very well from the very beginning, you will never get this classical feature, never. But only during your palpation you will get the finding. Before that, sometimes that's the difficult. But if you look at the eyes, there may be some pallor. If the child is already just before the day of exam, or maybe 2 days 3 days before the exam, the child is already transfused uh, um, you know the blood, then pallor may not be there. Pallor may not be there. But what you need to do, you need to observe the jaundice very carefully in abdominal case. Please, 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 just remember this one. Okay. If you are missing jaundice, your diagnosis will be in a wrong track. Your discussion will go in a wrong track. So jaundice you need to so classical jaundice may not be there, because if this is a chronic case, there may be just yellowish tinge may be there. And in this exam, sometimes they are not giving the classical case. Okay, so you need to see for this jaundice or yellowish tinge very carefully. So if you are getting jaundice, then definitely you are in the right track with hepatosplenomegaly, and they will ask for your DDs you presented, and you can put as like your DDs in malignancies. If lymph node and is there or not, you need to examine, and you can put your DDs in malignancy as well. Okay, if there is no such typical finding of your hemolytic cases. Okay, so if there is no jaundice, then you need to think about the metabolic diseases. Okay, just like MPS, glycogen storage disease, there are varieties of glycogen storage disease. You need to think in that particular way. Now they will ask, okay, in beta thalassemia, suppose this is a case of beta thalassemia, what may be the causes of this hepatosplenomegaly or hepatomegaly first? So what we know now, this is extramedullary hematopoiesis number one. There may be, at the same time, this is pallor, severe pallor, there may be heart failure, or there may be some associated infection. So these are the common causes, right? And investigation, as you mentioned, they will ask for investigation. How you will investigate this child? So, as we all know, that peripheral blood film, that there may be hypochromic microcytic anemia along with some tiered cells and target cells actually, and poikilocytes and blah blah blah. Everything that can be in the peripheral smear. And if this is already diagnosed, so no need to do electrophoresis. But if this is first time, so this is very unlikely that first time they will present like this. They will mostly diagnose case. So otherwise, you can mention the electrophoresis as well. And the ferritin level is very. If you are not maintaining ferritin level or chelation therapy, they will deduct more. Please, 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 in your notes, please keep write it down. Please, this is the information I'm giving you. Very important piece of it. If in your management you are giving everything, but you are missing the chelation therapy, they will deduct mark. If you are not mentioning the geneticist, again they may deduct mark. Genetic counseling is important in the management. And don't ever go to manage this child by your own. Involve the multidisciplinary team. Because in hurry or under pressure situation, sometimes we used to forget to mention the multidisciplinary team, including the hematologist. The role of hematologist is very important here, including geneticists. And they can ask about the features of iron. How will you measure apart from ferritin level? How can you measure the iron overload is there or not? So you can mention the MRI. Okay. So these are the part of discussion. But in clinical station, the problem is time management. There is no such time. In 3 minutes, there is. And if you know, because you need to know everything, we don't know which question will be asked in the exam in this particular 3 minutes of time. So be ready for that. And according to your question by the examiner, you need to answer. Okay. And they may ask about some complications of chelation therapy and when you will start, and any preliminary test, whether any test is needed before you are starting off chelation therapy. What may be the complications if this splenectomy has been done, then they will ask for the complications. At the same time, they will ask, okay, how will you manage? The splenectomy is another important area if you are not mentioning the vaccination, because somewhere they are expecting that you will mention the vaccination. So in splenectomy, the thalassemia patient or splenomegaly, chronic hemolytic anemia, you must mention the vaccination. Okay. So if you are not mentioning, they will ask for, okay, how you will manage this child if splenectomy need to be done. Somehow they will give some hints because they are wanted to know whether you know this vaccine. This is very easy, but you should mention. And these are marks continuing anyway. If you are in a right track, they will give full marks in abdominal station. Okay, so this is one variety of case. Okay. And this is most important, very common actually exam case. So prepare yourself. In abdominal station, what may be the other like say other varieties of cases? As we all know, splenomegaly, sometimes only splenomegaly may be there. You need to think about the portal hypertension first, and after that you can put the infective causes maybe. So in that way, that may also come. If you are getting the only hepatomegaly, again you can think of some storage diseases. So these are the way you need to think. And sometimes if their favorite area is also portal hypertension, so they will ask a little bit of more question about portal hypertension, especially if someone is presenting with variceal bleeding. So you need to remember, you need to prepare for that. Okay. So today I'm just giving some just superficial discussion. It's not going so much of detail because practice is more needed. So we'll move for the next case. Okay. So just prepare the abdominal cases. These are very important. Common case, but you can get. And Dr. Shantan, have you noticed there is a squint as well in this child?
I didn't notice.
Anyway, but if this is significant, then you should mention in your finding, and they'll be giving full marks for that.
Okay.
Oh, okay. Here is the next case. Dr. Winnie wanted to practice with this one, I think.
Yes, Dr. Pranab.
So this is a child. Name is uh, Jason. So Jason is 14 years of age, and he is complaining of joint pain after coming, school in the evening part. So your task, can you examine the child generally? So I'm keeping the time for you. Your time starts now. Jason is 14 years of age.
Okay. I wash my hands. Hello, Jason. How are you?
Yeah, Jason is fine as of now.
Okay. Can I go ahead and examine Jason today?
Yes, yes.
Okay. Hi, Jason. Who have you come with today?
Yeah, it's me and my father is there.
Okay. Good to know. Okay. All right. Jason, does he have any dysmorphism? I
As
can
it,
see he is,
Mhm.
I can see that he has somehow short neck. I cannot make out any features on the face. Does he have any dysmorphism in the eyes or anything abnormal?
Dysmorphism in the
Not
eyes.
making.
No, no, no,
Any other dysmorphism?
no. As you can see in this
Okay, and
picture, that's all.
okay, all right. And then does he have any devices attached to him?
No.
Okay. His how is his height, weight, and head circumference? I would like to plot on the age appropriate growth charts.
Yeah, a height he is tall compared to age, and
Okay, so
weight,
he appears to
yeah,
okay.
and weight is average and thin build, as you can see.
Okay. So I can see his thin build and he appears to be tall. So now I would just he's complaining of the pain. Okay. Apart from that, devices, any distress he has?
No,
Okay. So I will just make him stand, and I'm looking at Jason from front. On my examination, what am I seeing in the eyes? Is there any pallor or any yellowish discoloration or anything abnormal in the eyes that I note?
no.
Okay. And then in the mouth, how is his hard palate? Anything abnormal in the nose? How is his
Yes, high,
dentition?
high, high arch palate is there. Dentition is normal.
Okay. Any swelling in the neck I can see?
No.
Okay. I want to look at his hands. I'm just going to ask him to, I can see he's put his hands on the side and it is reaching up to mid thigh. I'm just going to ask him to put his hands in front. And I'm noting that he has long, slender hands. Arachnodactyly is present.
Mm.
Are there any contractures that I'm noting in the hand?
No contraction.
Okay. And then is he able to do the Steenberg sign?
Positive.
Positive. Okay, I want to go ahead and assess for Biden score. I'm asking him to flex his thumb to his forearm. Is he able to do that?
Mhm. Positive.
Sorry?
Yes, yes.
Positive. I'm going to ask him to do both on the right and the left. Then on the little finger, I'm going to ask him to flex over his forearm. Is he extending more than 90 degrees, both the sides?
Yes.
Okay. And when I ask him to hold his hands out, am I seeing hyperextension at the hands bilaterally?
Mm, yes, well, literally it is there.
Okay. So I'm just going to ask him to bend down. Jason, are you able to bend down? Is he able to touch the feet, the ground with both the hands?
Yes, easily.
Okay. I can see that he's also able to stand well. Is there some hyperextension as the knee as well?
No.
Okay, so I can see his Byton score is positive. I want to go ahead and assess his legs. I'm looking down on his legs. Is there any scar or anything that I note in the? I
No.
can see his foot is there. They are long toes present. So now I'm going to examine him from the sides. On the sides, do I note any contractures in his hand, in the elbow or in the knee joint? No.
No.
Any kyphosis that I can see? Any lumbar lordosis? I can't see anything there.
No.
So I go back and I examine his spine. I can see a bit of low hairline, short neck. But is there any scoliosis that I note?
Scoliosis, not so significant, like there, but not so significant.
Okay. And how is the shoulder level? How is the scapula? Are they at the same level? Is there anything that can suggest? Okay, you have said scoliosis already. I'm going to look at the back of the knee and the leg. Any scar marks that I note?
No.
And overall on the skin, am I noting anything, any bruises or anything?
No.
Okay. So to complete my examination, I would like to assess his CBS examination to look for any heart murmurs. I would also want to auscultate his chest to look for any features of pneumonia. He has a bit of scoliosis. I would also want to assess the P2 if there's any loud P2 that is present in his heart. And I would also want to complete my examination by doing a complete per abdominal palpation as well as staging his Tanner staging for
Okay.
pubertal assessment.
Okay. Have you done?
Yeah, I think so.
Present success 5 minutes and 40 seconds. Yes, you can present your case if you want.
Also to complete my examination, I would want to, as I said, plot his height, weight, and head circumference, and also the pulse rate, and wanted to note the character of the pulse. So today I have examined Jason, who is a 14-year-old boy. He seems to be tall for his age. He's thin and has long, slender fingers and toes. On my assessment, he has features of Marfanoid. He seems to be tall and thin. He also has he has Python score is more than 4/9, so he has features of hyperextensibility as well. His mentation seems to be very good, and he's not in distress. Keeping all together, he also has mild scoliosis that is present. So putting everything on my general physical examination, I feel he has Marfanoid features, most likely Marfan syndrome.
Okay.
Hello.
Yeah. So, what are the features that is suggesting of Mrcpch syndrome?
So Marfan syndrome, first they are tall. They have tall Marfanoid-like habitus. That is, they are thin and they have long, slender fingers. They also have hyperextensibility.
Have you got the typical facial features of Mrcpch?
Facial features, usually they have long faces. I have not picked that in this child. I don't find the face very long, but they do have eye changes, either refractive errors or lens dislocation will be present. He has high arched palate, which is also a feature of Marfanoid.
Okay. What are the other DDs?
Other DDs, I would like to keep other differential would be homocystinuria, which is a close differential, but however, his mentation seems to be very good, and there is no contractures that I could note in him, which is more common in homocystinuria.
Mentation is very good, you say?
His mentation was better. He could say he has come with his dad. His speech was good.
This child or like homocystinuria?
Here, in this child, he is
Fine.
Marfan. Yeah,
What?
I have ruled out homocystinuria
Okay.
because his.
Any other DDs?
I could also consider Ehlers-Danlos syndrome. However, I would like to check for skin extensibility. They also have tall stature. They also have Beighton score will be high, and one of the type of Ehlers-Danlos is Marfanoid feature. So it is possible that it is there. Sometimes they also tend to have bruises on the body, which he does not seem to have.
Okay. How will you investigate this child?
So in my investigation, first of all, there is no I would not want to do any investigation if he's already a known case, but if he has an underlying problem, so first will be I will like to have a multidisciplinary team on board. That is, we'll need an ophthalmologist to assess the vision, mainly looking for any lens dislocation, any refractive errors, any strabismus. Then we would need to have a cardiac evaluation by a cardiologist to look for any heart defects. They are known to have left-sided heart defects, so that can be evaluated. Also, he has scoliosis, so we will need an orthopedic surgeon to evaluate the degree of scoliosis and if he needs any support there. And geneticist will be important because it is usually autosomal dominant condition, and that's why we need the geneticist. And he is complaining of joint pains, so also an orthopedic surgeon and physio and occupational therapy.
Okay, thank you.
To
Thank
relieve
you.
him.
Yeah, your time is up. Okay, well done. So what you missed in your examination, can you remember?
I think I missed the chest deformity. I think he has excavatum, is it?
Yes, Byton scoring is must. So for everybody, please. This is another tricky station actually. If you see the recall again in Jeddah, maybe in day one they are given hypermobile joint. So never ever give your diagnosis whenever they are asking for diagnosis. Do not mention directly Marfan syndrome or homocystinuria or like Ehlers-Danlos. Never, because this is we are not they will think that somehow this a candidate got to know the case. Okay, so don't ever mention directly not only here, in every station give your diagnosis, provisional diagnosis or most likely diagnosis in a broad spectrum. Just like if you are getting thalassemia, don't tell this is a thalassemia. So this is chronic hemolytic anemia, most likely thalassemia, maybe other disease as well. How would I know? I can suggest only. So be like a human being, not like robot. Okay, so not like computer. You're going to examine and you are just after assessing the child, you directly coming to the diagnosis. This is a case of Marfan syndrome. This is very unlikely. I mean, this is likely. So don't. So if you suggest your diagnosis, it's most likely hypermobile joint. Maybe your most likely diagnosis is either like you can put your Ehlers-Danlos syndrome first, or maybe if there is Marfan, typical Marfan features, then you can put your Marfan syndrome first and then Ehlers-Danlos, then your other cross-stitch, that's the homocystinuria. But here, what you missed in your examination, that is your arm span. Arm span is important if you have long, like cross-stitch cases.
Doctor,
And
here our differential, is it Marfan versus homocystinuria or Ehlers-Danlos? Ehlers-Danlos they have hyperextensible joints, but they are not tall.
maybe sometimes they are not tall, but if you are getting any hyper extremism, they are not always tall. That is the exact sentence. Because sometimes that will discuss. I will discuss that. Okay, can you mute please? Yes. So I will discuss this part today. That's why I have selected this case. So you are right. Whoever who was this? Dr. Anam. Who was telling this one? Hello.
That was Dr. Raja. She was saying that.
Yes, doctor.
Okay,
Yeah,
Dr. Raja, you are absolutely right. I will come to the point actually. That's why I have selected this case. Just a minute.
No, but then Dr. Pranab, in Ehlers-Danlos there are different types, and Marfanoid type of Ehlers-Danlos is also one of the types. So in that type they can present as
Yeah,
one stage.
that's why I'll discuss that. Just a minute.
And Ehlers-Danlos, there will be specific skin scar. Am I right?
I'm coming. So
Okay.
the thing is, this type of cases, if you get in your exam, that sometime sometime you can get some confused during your examination. Why? because this is another case. They're one of the favorite case. Mostly in the UK, sometimes they are giving mostly, and in the overseas, as we have seen in the Jeddah last time, that has been given. So if you know, observe the child and expose the child. That is the key again. Observe the child, especially start with the face, and after that, after exposing, if you are suspecting this child, the opening statement maybe there is pain during when the child is walking, but actually there is no such pain during your examination. Because of hypermobile joint, there will be complaining of pain. But the thing is, there are varieties of cases. Number one, as I said, if you are getting any tall stature cases, that your differentials may be number one, Ehlers-Danlos or Marfan, or maybe homocysteine. Now the problem is with EDS. Why? And they are most frequently giving EDS. There may be no such, cardiovascular involvement, or the child may not be. But the problem is with EDS. Now, EDS child, according to the variety, as Dr. Wayne was telling, according to the variety, not always the tall stature. Tall stature may be one of the variety, but there is, some varieties of hypermobile joint in EDS. They are not so much of tall. Okay, so in that particular variety of cases, you can get, you may, confused in that in the exam hall. You are not getting any finding. So what happened in one of our colleague who used to practice with us previously, he went to UK for her exam, and everything was normal. According to her, everything was normal. So the task was do general examination because the child is having complaining of pain, and do the MSK examination. Maybe I can't remember the opening statement, but in her examination, there was everything normal. And then the examiner told, "Have you checked the joints in the hand?" So there were hyperextension of the elbow joint. Okay, bilaterally. So at that time, after giving hint, she understood this is something different, not expected, like whatever she expected. The case was EDS, and somehow she missed the case. So that is typically the problem with this kind of cases. So this is one variety of case that is sometimes maybe confusing for the candidate, but this is at the same time one of the favorite case of us. One of the favorite case of Royal College. So please again be little bit of careful whenever you are getting a child with lean and thin, and sometimes that then child may have long cylindrical, this spiral kind of hand and flat foot, and you are suspecting this is most likely hypermobile joint. Just complete your examination as per technique. This hypermobile joint examination technique, including the weight and scoring. And after that, you need to present your case. But if you are doing the just weight and scoring, and after that you are picking up the general finding, you will get maximum marks if you are in a right track thinking. This hypermobile joint most likely EDS. Okay. So that's why I have discussed this case. This may again come because this is one of the favorite case of there. You need to be little careful. Okay.
Okay,
Dr.
Particularly,
Pranav,
and
I
here
have a
we
question.
should give we should give a broad
diagnosis, right?
category,
Hmm.
broad category, maybe 1, 2, 3, 4.
Yes.
I suspect with one, my provisional, 1, 2, 3, 4.
Right.
And here maybe we should do the hyperelasticity. We ask the patient to pinch out his skin.
Yeah. She mentioned that.
Right?
Yes, right. So skin is elasticity, we need to check. So in that way.
Only the difference between Marfan and Ehlers-Danlos with skin elasticity.
Skin elasticity, definitely. And the faces sometimes may vary, Marfan, you will get long faces. Sometimes in Elias may or may not be present, right?
Yeah.
And there may be some bruises. Easy bruisability will be there, so you can get some ecchymotic patches or like bruises actually. Okay,
Yeah.
so you need to be.
Cigarette-like scar, maybe sometimes.
Yeah.
Yeah.
These are the features you need to pick. Okay, that's why this
Dr.
case.
Pranab, if the task is do general physical examination, we are not touching the patient, right? We are only explaining the inspection findings. Are we allowed to see the pulse and do the stretchability or auscultate the heart, anything like that?
No. That is, there is no such strict like any demarcation. So this is if your task is general examination, you can do. You can do check, like pulse. You can ask the child to bend down and see the hyperextensibility of the elbow joint, and sometimes you can ask the child to walk. Because I have got the general examination of that severe post-operative case of your spinal surgery. Whole spine was lengthy scar was there. So the task was general examination. If I asked them, I asked the child to walk. Otherwise, I may miss some finding in the hip joint.
No, walking is fine because walking you're still inspecting the child. But is the palpation and auscultation all that allowed in general physical?
No.
Should we do if we
Auscultation
have time?
no. Auscultation and palpation. Before that, you need to take the permission. Sir, I would like to auscultate the heart, or maybe the chest, or maybe the I would palpate. I would like to go for abdominal examination for more detail. So for that reason, you need to take the permission. This is the protocol actually. Otherwise, you can check the pulse. You can make her walk or whatever. If the movement actually, you can check definitely. So this case again may come. That's why in other station. Yeah, please.
This case was associated with cor pulmonar or with aortic regurg or mitral regurg.
Yeah, the cardiac finding may be various type of cardiac finding may be there. So I'm not going into the detail. Okay, because if according to the lesion, there may be aortic regurg most commonly, right? So that collapsing pulse you can get like pulse whenever you are examined, because there may be what am pulse positive. So cardiac examination is different that will be in the cardiac station. So if most commonly they'll be giving without any like cardiac lesion, but without any your cardiac examination. General examination is most likely they'll be giving. But if you are getting any case looking like Marfan or like hyper mobile joint, along with you are getting scar maybe in the chest, so think of spontaneous pneumothorax chest joint scar. Okay, and if you are getting any scar over the midline, there may be sometimes that is aortic. This root dilation, sometimes they have operated, so some scar you can sometimes get, but that is also uh, very unlikely. But you need to know actually why this scar is there, because of this cardiac lesion. What may be that cardiac lesion which has been repaired previously. So that's why you need to correlate your finding with the like the features whatever you are getting in this child. Okay, so in this way, and in the management part, never ever forget to mention the geneticist and to examine the parent, or maybe there may be an autosomal dominant condition something. No? So that's why we need to examine the other family member. Okay. So these are the important areas, and again, time is very minimum. So you need to very specific during your examination. Otherwise, you may miss some finding or your presentation or discussion with the examiner. Okay, so that's why. Anyway, so I'm giving you another case. I think Dr. Vinodini wanted to practice.
Yes, sir, I'll do.
So I'm giving which you want to do clinical or any other specific your
Anything is okay, sir.
anything okay. Okay, fine. Okay, so here is just a minute. Yeah, show you the screen. Your task is to examine this child. Yeah. So 10 years of age, Farhan, you need to examine Farhan, examine his CVS.
Okay, sir. Shall I start?
Just a minute. Your time starts now, please.
Yeah. So, hi, I'm Dr. Vinodini. I'm one of the pediatric doctors here. Hi, Farhan. How are you?
Yeah, I'm fine.
Yeah, okay. So I'm washing my hands. I'm asking Farhan's mom's permission. So hi, mom. I have been asked to examine Farhan. Is that okay for you?
Yes, please.
Yeah. Okay. So hi, Farhan. So I would just like to keep the steth over your heart, and I just would like to listen. Is it okay?
Yes, please.
Yeah. Okay. Can you please remove your shirt? So I'm
Yeah.
helping him. I'm removing his shirt.
Yeah, remove.
So I'm. For me, so I'm looking in the surroundings. So is there any devices or any medicines, anything attached here?
No.
Okay. So I'm looking at Farhan. I can see there is dysmorphism. Uh, uh, so he looks like he's having features of Down syndrome. And how's the child? Whether the child is in distress?
No.
Okay. So I would like to plot the child's height and weight in the appropriate growth chart, in the Down syndrome growth chart.
Okay.
What
Okay, continue, please. No need to mention.
Okay. So I'm asking Farhan, can you show me your hands? I'm looking at his hands. Is there any clubbing? Is there any cyanosis?
No clubbing, no sinuses.
Okay, I'm asking him to show this diamond sign, and I'm looking for the clubbing. Is there any clubbing?
No clubbing.
Okay. So, and then I'm coming down, I'm palpating his wrist on the right side. What is the pulse rate, and what is the character and rhythm of the pulse?
This is 70 per minute. Character is normal, no special character, and rate is also normal.
Okay. So now I'm palpating on both the sides, and
Mhm.
is there any radio-radial delay?
No.
Okay. So I would like to check the BP later. Now I'm asking him to, can you lower down your eyelids? I'm looking for any pallor.
No pallor.
Okay. So I'm looking at his mouth. Is there any high arched palate, or is there any how is the oral hygiene?
Oral hygiene is good. High ash palate is there.
Okay. So I'm okay, Farhan, can you please lie down for me? So he's lying down. I'm going to the foot end of the bed, and I'm inspecting his chest for any precordial bulge. Is there any precordial bulge?
No.
Okay. So is there any visible scars?
Yes, there is a midline scar.
Okay. Um, is there any other visible pulsations? Is there any other small scars or any dilated veins?
Yeah, a small drain both the sides is there.
Okay. Okay. So now I would like to palpate his chest. I'm keeping my both hands over the right and left side. So I'm feeling for the apical impulse. Where I'm feeling, the right side or left side?
Left side.
Left side. I'm taking my right side hand, and I'm palpating for the apex beat. So where exactly I can locate the apex beat?
It's a fifth intercostal space and the mid clavicular line. Left side.
Okay. So what about the character of whether it is like heaving, normal, or tapping?
No special character.
Okay. So and now I'm palpating over the other areas also. Is there any palpable heart sounds in the pulmonary P2? Any palpable P2s?
No palpability.
Is there any thrill over any area?
No.
Is there any heave?
No.
No heat. Okay, sir. Okay, so now I would like to auscultate his chest. I'm auscultating in the mitral area. So what about S1, S2, and is there any murmur?
Well, S1 and S2 now near normal.
Okay, is there any murmur?
Soft ejection systolic murmur, but it is very soft in pulmonary.
Okay. No, I would like to auscultate on other areas also, tricuspid area. Is there any murmur in the upper, like in the pulmonary area and the aortic area? So what about S1, S2, and is there any murmur?
S1 is normal, no other area, there is no murmur.
Okay, so only in the mitral area, I'm hearing a soft ejection systolic murmur. Other areas, no other murmurs.
Not mitral, it's a pulmonary area. There is ejection systolic murmur that is very mild, grade 2.
So in the pulmonary area.
Mm.
Okay. So, okay, so now I am auscultating in the, I'm asking Farhan to sit. Farhan, can you please sit for me? And I'm asking to like take a deep inspiration and expiration. Is there any change in the intensity of the murmur?
Well, no.
Okay. And I'm auscultating in the axillary region and in the back. Is there any radiation of the murmur?
No.
No radiation. Okay. Okay. And I'm now I'm auscultating on bilateral basal lung fields also to look for any crepitations. And then I'm just palpating the liver for any hepatomegaly, and I'm looking at the legs for any edema, fetal edema.
Yeah, thank you. Your timing is
And I'm
very
looking for the blood pressure also. I would like to examine.
Just a minute, huh?
Sir?
No, not for you actually. Sorry, I'm asking for water. Actually. Okay, so present your case, please.
Okay, so I had an opportunity to examine a 10-year-old Farhan. So for an general examination, he has features of Down syndrome, and there is no cyanosis and no clubbing. On inspection of the chest, he is having a midline stenotomy scar, and there are two scars which indicates like drain scars over the lateral side, and and the apical impulse is on the fifth intercostal space in the midclavicular line, and there is no specific character. On auscultation, there is a soft ejection systolic murmur in the pulmonary area. There is no change in intensity with inspiration or expiration, and the murmur is not radiating to the axilla or the back. And there are no other signs of infective endocarditis and no features of cardiac failure. My most probable diagnosis is that it could be like a repaired acyanotic congenital heart disease, could be a, VSD or an ASD or a PD.
Repaired, you said, no?
Yes, sir.
So how will you explain the murmur?
Like or it could be like on like since it is a Down syndrome, like atrioventricular septal defect can also be a possibility. So because of that pulmonary.
Describe the murmur first.
Sir?
Can you describe the murmur first? What you have got here?
So I heard a soft ejection systolic murmur in the pulmonary area, sir.
Yes. So that was a little misinformation from my side actually. That varies with respiration, and I'm sorry for that. Huh? And now, what is the disease of this murmur?
This it can be like because of pulmonary hypertension or a pulmonary stenosis can cause this murmur, sir.
Okay, so I said S1 and S2 is normal. So why you are thinking pulmonary stenosis? There is no my back reduction.
Residual, yes. Sometimes it can be like innocent murmur also can present like that.
Yes.
But since there is scar, midline sternotomy scar, the child is like post-operative.
Property. Okay, your
Because
time
of,
is
can
up.
we do the
I'm
flow
just
murmur also, sir? Because of like it
yeah,
used to flow across the pulmonary wall.
So say loudly, say confident you are. You are so much of a no, you're not confident. You are, have you got the seat, I think, right?
Yes, sir.
So
Sir,
be
sir.
confident.
Increased flow across the pulmonary valve can
Yeah,
cause this.
yeah,
Yes, sir.
that can be slow murmur, that can be your innocent murmur. So it does not mean whenever you are getting any kind of post-operative case, just like not only downs, that maybe in other cases you are getting any median sternotomy scar with two like your drain scar. That does not mean that every time you will get the murmur. If you are getting the murmur, try to evaluate the murmur carefully. That may be, flow murmur, that may be benign, like innocent murmur. But does not mean because the child is well grown, there is no such cyanosis, clubbing, nothing is there. That may be acyanotic. As you initially that you are absolutely right. Then again, why you got confused, I don't know.
Yes, sir.
So the beauty of this exam, or sometimes no threat of this exam is, what? Do you have any idea? So whenever we are losing our confidence, that is the threat. So be like whatever you are getting in that particular child, present your case just like this. That does not mean that you are getting a like scar and you are making, you have started to make your finding. That is the dangerous area. Never ever make your finding. You may even get 0 for that.
Okay, sir.
So the thing is, if you're getting any scar, try to listen the heart carefully and evaluate the S1, S2 along with the systolic, diastolic murmur. Diastolic, they are very unlikely that diastolic murmur will be in the exam. Very unlikely, but the child will be sick enough. So most of them are either systolic or pansystolic. So the thing is, never assume that there is scar, that means there will be murmur, or the murmur is most likely due to you have read so much the books but you forward whatever you are getting, your mind will be trying to correlate the finding. If some finding is not there and you are adding the finding to complete your case, that is the risky area. Don't ever make this kind, whatever the finding is present like that, not only in CVS, even neuro also. So as I said in my discussion, in my our few my colleagues are also giving this exam. So I said, if you are getting a case of neuro, there may not be your classical finding, but whatever you are getting the finding, try to present with this finding, and try to explain why, what you are expecting and why this finding is not correlating with your finding and with your diagnosis actually. For my point. So this is natural, the human thinking. So if you are, so much of strong in your theoretical knowledge, and after getting, started with this car, you are getting, giving the finding of like mitral, pulmonary regurg or pulmonary stenosis, that is not expected here.
Okay, sir.
That is the main thing of this. So cardiovascular system is not so much of difficult, but if you're familiar with the various type of murmur, that will be easier. So it is mandatory, all of you, please go through the murmur, maybe in your clinics or maybe in cardiology unit, just for a 1 or 2 day before your exam, or maybe your exam is nearby. So please hear the murmur carefully, and whatever you are getting the murmur and the particular area, try to explain the murmur according to the site, according to the I mean whether this is systolic or diastolic. So according to your finding in your clinical examination and according to your site, you can give your DDs. This is the key to pass this station. Otherwise, what happens sometimes in post-operative cases, especially post-operative cases, you may never get any exact diagnosis because there may be various types of murmur, and examiner are looking whether you are making any finding or not. So whatever you are getting, maximum intensity, you need to find out maximum intensity and whether this is systolic and diastolic and the area. Find out this thing, and after that you just present your case. Okay, that is the key basically. Otherwise, there may be some problem. Okay, so this is the thing, and rest of the thing you picked up very well. This is definitely Down syndrome. There is no doubt about it. And the child is not so much of well grown, but a Down syndrome child automatically, just having some not according to the growth chart, a special growth chart, you need to evaluate. There may be stubby finger, single comma PS, and pivotal delay maybe sometimes, and you can get some next value sometimes posterior, this rotated ear, flat occiput, and you need to talk to the child because something IQ, low IQ will be there, developmental data will be there, and yeah, there's a higher aspect you find it out, and there's sometimes large tongue and short neck, waving of neck, and various finding will be there. You need to add the finding during your presentation. Some if you get, the time. Okay. Otherwise, because of your task is mostly cardiac, so you should focus on your cardiac, and you should mention this is a most likely Down syndrome, and the features is like, and these are the features. I have Down syndrome, and like by cardiac examination, I have got this finding. So this is most likely this post-operative case of blah blah blah. Okay. So investment.
Okay.
So overall discussion, do not presume or just like fix your mind with theoretical knowledge that you are getting a Down syndrome means there will be AVSD. You are getting a child with Downs, that does not mean there will be VSD. That may be ASD as well. So this finding, you need to pick it up. This is basically, I wanted to discuss this thing with you. Okay. Anyone? Next, management part everyone knows. I'm not going to detail. So investigation management is very easy. Anyone wanted to practice? Maybe just normal heart. Yeah, absolutely, Dr. Raja. Well said. There may not be even one.
Yes. Yes,
Even- yes.
yeah, many children with Down, we were examined, normal heart without any defect, congenital defect.
Exactly.
Doesn't mean that they should have heart defect. The
Exactly.
majority, yeah, we have to screen them, but
Mhm.
not necessary to have even 10 years without any scar, and without, if he has normal growth parameters, is that mean that he has normal heart? And what we hear may be innocent murmur. To show
Right.
us, to show our work, we have to do the maneuver while to do inspiration, because at the pulmonary side, by changing the position and by inspiration, does it change or not?
Right.
This means that we are know what we are doing.
Right. Absolutely
Right?
right.
Yep.
So that is the basically beauty of this exam. Someone after you, I know you are in a stressful condition right now. Even every one of us, went through this particular time. But once you pass this exam, you will feel that this is the beauty of this exam. So this is just like will make the difference between a good doctor and some other doctor actually. So
Absolutely.
that's why, that's why this exam is. Anyway, so anyone willing to practice?
If no one want, I will be. But
Okay.
the priority, the
Okay.
participant. Yeah.
Okay, anyone exam going? Will do then, otherwise.
Yep.
Another CVS we can do, okay?
Another CVS, okay.
Yeah, our CVS is mandatory in the exam. Most likely you will get. 100%. CVS, without CVS and CNS, the exam is incomplete. So this is the case. 10-year-old child, Max. Kindly examine in the the CVS.
The CVS, yeah. I enter the room already. I washed my hand. I give my mark sheet to the examiner, and I want to take permission of Max's mother.
Please,
Can
go
I
ahead.
examine your? How are you? I'm Dr. Raja. I'm a candidate today. Can I examine your child, Max?
Yes, please.
Yeah. Hello, Max. How are you?
Yeah, Max is fine.
Yeah, I want try to speak with him to assess his mentality and speech. Any abnormality in his mentality?
Yeah, normal.
Yeah. And is he in distress?
No, not in distress.
Yeah, and he has down slanting eyes and lucid ears with short neck, and I think it's webbed neck. Yeah, and yeah, he looks dysmorphic, yes. And does he connect it to any device like
No.
or to any medicine around him?
No.
Yes. Just now I want to start with examination with his hand. Max, can you give me your hand, please?
Yeah, Max is giving.
Yeah. Yeah. Is there any clubbing?
No clubbing.
Any cyanosis?
No sinuses.
Any multiple cannulation?
No.
Yeah. Now I'm checking his radial pulse. Is it regular?
Regulars.
The count?
70 per minute.
What?
70.
70. Yes, I want to do radial.
Normal.
Yeah. Can I do radiofemoral? Can I check?
No
if there
need.
is any-
No need.
No need. Yes, I want to do water hammer.
No need. Continue, please.
Okay. What about the axilla? Any lymph nodes or any?
No lymph
Still, he looks not to get his puberty till now. Yeah.
Yeah, no pivotal sign.
Yes, I'm looking at his neck. Any pulsation? Any scars?
No. Negative.
Yeah, negative. I want to check his eyes. Does he wearing glasses, eyeglasses?
No glasses.
Yes. Is there is pallor? Can you, Max, please, can you get down your lids like me, like this? Is there any jaundice, pallor, or redness?
No jaundice, no pallor,
Yeah.
no redness.
Yeah. Okay. Is there any around his ear, any hearing aid?
No.
Okay. Can you please, Max, can you open your mouth for me?
Yeah, high-ash palate is there.
Yeah. Is there any cyanosis?
No.
What about the mouth hygiene?
Normal.
Normal. Does he has any high arch palate?
Yeah, I said there is high-ash palate.
Yeah, I can't get it. Okay. High arch palate. Okay. And I want now to start with local examination. Is there just from the front of the bed? I want to check is there any pericardial bulge and pulsation?
No pericardial bulge, no pulsation.
Yes, and any scar?
No scar.
I'm now at the right of the his side, and I'm checking if there is any scars. Can you raise your hand around your neck? Is there any thoracotomy scar?
No scar.
Okay. Max, please tell me anything is hurting you at your chest?
No.
Okay. Just I want to do is just to touch your chest, if you don't mind, Max. Okay.
Sure.
Yeah. Now I'm making my both hand as a butterfly, and I'm now checking his apex. At what side the apex?
It's a left side mid-clavicular line.
Yeah. Also, I want to check the heart. What about this one? Is it felt at the same
S1,
side?
S2. Yeah, S1, S2 normal.
This one is too.
S2 bit soft.
Yeah, it's felt S2.
S2 is soft.
So, soft, but it's palpable. Okay, is there any thrill at the apex area?
No,
Okay, now I'm checking his tricuspid area. Is there any thrill?
no,
Can I feel any precordial
no,
heave? No,
no.
precordial heave. Yes. Is there any? I checked the S2 at the left intercostal space. Is there any pulsation on the right second
No.
intercostal?
No.
Is there any suprasternal notch thrill?
No, no,
Yes. Any thrill at the neck?
no.
No. Now I want to auscultate by S1 at the mitral. What about S1?
S1 is normal, S2 is soft.
Yeah. S2 is soft. Okay. Is there any murmur at tricuspid area?
Actually, the murmur is mostly that is in the second intercostal space in the left side. But this murmur you can also
just the voice is
you are getting ejection systolic murmur in the second intercostal space, but the same murmur you can also hear in the left lower
at the third lower sternal area.
Yeah, but the maximum intensity is here in second.
S2, yeah. Any murmur at the right side?
No, same murmur you can have the lower intensity.
Yep. So can you sit down, Max?
Yeah.
Now I want to hear his back intrascapular. Is there any murmur there?
Yeah, there is this radiation of the murmur.
Okay. Now I want to. Can you take a breath, Max, and let it out?
Yeah.
Yes. Is there any basal crackle?
No basal.
No basal crackle. Okay. Can you lay down, Max, please? Thank you so much, Max.
Yes.
Yeah. I want to check his liver. Is there any enlargement of liver? Now I want to go to his lower limb to check if there is any clubbing cyanosis.
Okay. No.
Yeah. Now I want to complete my examination with taking his measurement and plot it on the growth chart. And I want to do abdominal, where his abdomen to check if there is any renal bruit.
Nothing.
Yes. Nothing.
Okay, your time is up. You can present.
Yes. Today I have the opportunity to examine. Thank you, Max. I cover my Max first of all. Today I have the opportunity to examine Max. Max is a 10-year-old male. He has average normal mentality. He has Noonan syndrome features in form of low down slanting and eyes and lucid ears and hypertelorism and with the epicanthal fold. During examination, he has no clubbing, no cyanosis, not in distress. And I found during auscultation that there is ejection systolic murmur. Maximum intensity is on the left second intercostal space that radiate to the third intercostal and radiate to back. And this is a cyanotic congenital heart disease in syndromic child. Most probably pulmonary stenosis, and yeah.
So what are the DDs of your murmur? Whatever we are getting here. Murmur. DDs of murmur 1, 2, 3.
1, 2, 3 it is a grade 4.
No. I am telling what are the DDs of this area. You are getting the murmur. You said what are the DDs of murmur? What are the other murmur? Maybe you are getting.
Yes, other murmur that cause this murmur. Maybe PDA.
ASD, yeah, and PDA ASD, and it should be pathological, yes.
Okay, how will you differentiate between ASD and PS?
Pulmonary PD and PS. But why can I feel PS2? This is what make me confused a little bit, doctor.
Sorry?
Yep. Yes, the ASD, there will be separation, widely separated the S2. And ASD fixed.
Fixed splitting, right?
Yes, fixed splitting, yeah.
And
ASD may be associated with the right side hypertrophy. Here I didn't elicit the right-sided hypertrophy.
okay, so hypertrophic, how can you elicit it here?
Yes, I can elicit the there will be upward deviation of the apex beat, and there will be a pericardial parasternal heave. I can elicit. Yeah.
Okay. So, what are the investigation you will do in this trial?
What?
Investigations.
Investigations, first of all, after revision, his taking history and revise his note and what done for him previously, I have to do electrocardiogram, and I want to do for him, if necessary, chest X-ray, and I will involve the cardiologist for follow up with the echocardiogram. And I want to do for him full blood pressure on all his limbs and auto saturation also on all his limbs. Yes. Okay. And yes, I want to do, if not diagnosed yet as non, I have to do for him genetics, involve the genetist to confirm the diagnosis, and to screen, as it is autosomal dominant, I have to screen the family if they have same features or not.
What are the
Yes.
how you manage this child with this investigation you mentioned, but how will you manage this child?
Yes, I have to insist for him to follow up with cardiologist, and the advice about piercing and tattooing, and piercing and exercise according to cardiologist advice, if he will advise him for advice or not. And pulmonary stenosis, no need for prophylactic antibiotic for infective endocarditis. Am I right?
Yes.
Yes.
So that is dependent of the with the opinion of your cardiologist. If this is severe enough, then according to the lesion, they will decide.
I can't understand you because the voice is cracking.
Okay. So that we will take the opinion of cardiologist.
Yeah.
That's what I said.
Yeah.
Okay, well done, Dr. Raja. So yeah, I think you were well prepared, but I have not strictly keeping the time for you, because I wanted to complete this the session for you. So that's why I
Thank you.
given
But what about my speed? Is it average?
No,
or...
yeah, but this is online now. That's why that's very difficult to say. But when that will be with patient, you need to improve your time, because you need to keep maximum timing as much as possible for auscultation, because auscultation is very important in cardiac station.
Yeah.
Right. So that's why I try to be little faster in general examination, pick up the clinical finding, and come very quickly to auscultatory part. Because in CV station, that is a must station in this exam, and that is if the case is easier and we are unable to pick up, that is not expected actually. So that's why it's better to pick up the murmur as much as possible quickly. So give maximum time for your auscultation.
Yep. Thank you.
So you need to cut down your timing in the examination, general examination. You have took a lot of time. Otherwise, I think, have you got your seat?
No, not yet.
Okay, good. Okay, you are well prepared. Keep preparing. Okay.
Thank you.
Yeah, welcome. So, guys, I think we'll just stop here today, and again we'll arrange. Maybe whenever I am free, I will just try to help you out. Okay. Hello.
Thank you. Okay, thank you, Dr. Pranab. Thank you so much.
Thank you.
Thank you, doctor. Yeah,
Thank
thank you
you.
for your time. Thank you.
Thank you.